Well, welcome everyone to the inaugural Employers Healthcare Alliance Summer School Series. Today, we're going to talk about FlyteHealth, cardio-kidney-metabolic care. Boy, that's a mouthful, Pete. It's about GLPs. You know, how many of you have heard about GLPs? I don't think you can turn a corner or have a conversation today where they're not talking about GLPs. So today we're joined by FlyteHealth, and it's an organization that helps employers address some of the most challenging concerns. Of course, GLP, but obesity, health concerns, those that are facing today's workforce, diabetes, hypertension, chronic conditions. I mean, you can't turn a page without talking about those today, right? So over the next 30 to 40 minutes, we'll explore FlyteHealth and their approach to GLP-1 care, but it's more than just GLP-1. There's a lot going to be packed into this webinar that you're going to want to, it will be recorded, but you're going to want to listen to and float up to your management or to your employers, and really how it's going to benefit the measurable outcome, how it's going to benefit your employees, your clients. Again, GLP-1 is so prevalent, we have to get some help out there. So we'll be posting questions throughout the webinar. Feel free to raise your hand and we'll address those questions or answer those questions. It'll also be recorded, and I'll be posting it in the Employers website, Employers Healthcare Alliance website, and LinkedIn. But let's meet Pete now from FlyteHealth. Pete, if you can just introduce yourself and give us a little overview of FlyteHealth, I'll turn the screen over to you.
Thank you very much, Kay. I head up our strategic partnerships. So our partnership with Employers Health Alliance is one of those. And we are physicians, basically. I'm going to share my screen here now.
Oh, please. Okay, great. Just wanted to make sure.
So who is FlyteHealth? Well, we are American Board of Obesity Medicine Physicians. That is a relatively new specialty in the field of medicine. It's a specialty just like endocrinology, orthopedists, and it was founded, really the specialty was created by one of our co-founders, Dr. Louis Aroney. He founded the American Board of Obesity Medicine in 2011 because his research in the industry has now realized that obesity is a chronic condition. For decades, the medical profession did not realize that this is actually a chronic condition that can be treated not only with medication, but with lifestyle changes. As you all know, lifestyle changes alone are very difficult to do long term. But with medication, it can help facilitate and control portion control, help people reduce their appetite. However, there are a lot of different problems with GLP-1s, but our doctors have been treating people with obesity for decades, primarily using other medications than GLP-1s. As you know, GLP-1s were not really approved until a couple of years ago for weight management. So our physicians have been using, and I'll show you a list in a minute, a lot of other medications that actually promote weight loss, but they're much, much less expensive than GLP-1s, but highly effective, especially for people with BMIs less than 40. For people with BMIs.
Let me ask a question real quick. I mean, everybody's talking about GLP-1, metformin. I mean, there's even phentermine, and all of those things have been out there for a long, long time. Are you saying that, hey, not everybody is going to need to be on a GLP-1?
Correct. And most physicians, primary care physicians, are not aware of this. Certainly most consumers are not aware of this. So they see all the commercials,
right,
and they talk to their friends, and they immediately go tell their doctor, I want a GLP-1, and all they really need to qualify is have a BMI over 30 or a BMI over 27 plus one comorbidity like hypertension or hyperlipidemia. The
So
reality
do
is,
you think it's important, what sets Flight Health apart, I think, is having the board certified obesity medicine doctors. Do you think that makes a big difference in understanding it's not just, hey, I'm going to give you this, this is the rage today, that actually understanding that there's other opportunities?
yes, absolutely. That is the biggest point of difference is that we have 40 in-house, meaning 40 employees who are American Board of Obesity Medicine physicians, plus nurse practitioners, registered dietitians, a total of 80 in-house clinicians, and they're all trained in managing obesity. Now, you notice on this slide, we treat, since obesity causes so many other conditions like type 2 diabetes, hyperlipidemia, hypertension, prediabetes, we treat all of those conditions, primarily focusing on reducing weight as the core cause, but we also prescribe statins and other medication to help with hyperlipidemia, blood pressure medication, and so on, because we're treating the entire cardiometabolic condition. And you can see that we're licensed in all 50 states. We've been doing this since 2018 as a virtual care company. And so we have a tremendous track record. As you can see on the very bottom bullet point, we have an 86% adherence rate, which means we are successful because our physicians know what type of medication is going to provide the least amount of side effects, the right dosage, as well as all the other medications that they're on, all the other conditions they may have. It all comes into a treatment plan that our physicians create that determines what is the right medication strategy. And 70% of the time, it's not a GLP-1. And yet we're still able to achieve an average of 16% weight loss and achieve all the other cardiometabolic improvements in reducing HbA1c, reducing hypertension, reducing hyperlipidemia, and literally reversing type 2 diabetes.
So isn't it interesting when you look at, you know, all of the rage right now is GLP-1s, right? And now there's so many commercials on and the prices are coming down and all of that. But focusing on GLP-1, I think people get a little bit of tunnel vision. It's weight loss, it's obesity, but they're so interconnected. You almost can't have one without the other. There's a cause effect. And so I like what you say about treating the whole person. You're treating their conditions, not just their one symptom, if you will.
Correct. And we as physicians can prescribe all these other medications because the reality is, as you start to lose weight, the other medications need to be adjusted. You may not need high blood pressure medication. You may need a different form of statin. 30% of the patients we treat, because they're typically on a lot of different other medications, on 30% of them, they're actually taking weight promoting medications and they're not aware of that. Sometimes there's some anxiety medications or beta blockers that actually are weight promoting. So we consult with their physician, either their endocrinologist or their primary care, whoever they're seeing, and offer an alternative weight neutral medication to do the same thing. So that's just an example of the expertise we have. And since we've been doing this for well over 15 years, our treatment algorithm takes into account all these different options so that we can make sure they're on the right combination, whether it's a low dose GLP-1 in combination with some of the medications, Kay, that you mentioned, metformin, phentermine. There's a whole list of well over a dozen
Hey,
weight loss promoting medications that we use that are pennies on the dollar compared to a GLP-1.
but the other part to that, Pete, is I think folks are looking for a magic bullet. I think just about everybody is like, hey, give me something that I can continue to eat the way I normally eat. I don't have to exercise. I don't have to do all these things. There's no accountability. I think that's what sets Flight Health apart as well. It's not just prescribing a medication, you go on your way. There's the accountability involved, right?
Correct. We also provide, in addition to 4 virtual visits, this is not AI, this is not asynchronous. These are virtual clinic visits, just like an in-person, in brick and mortar visit would be. A full hour with the very first meeting your physician, who you'll see then 4 times a year. You'll see your dedicated registered dietitian 4 times a year. So every 6 weeks, we're going to have a clinic visit, virtual visit with you. And in between, you can communicate with our app, communicate with our care team through our app, which is part of what you download as part of enrollment. So our app allows you to, we'll give you a cell chip enabled scale, a cell chip enabled blood pressure cuff. If you have hypertension, all you have to do is put the battery in, turn it on. It's automatically tied into your account, which is then also automatically tied into our care team. So you can message directly to your doctor, your message your registered dietitian as they work with you on tweaks to your diet, making sure you have the right protein. But this is about portion control, which is helped by medication, but also helping you tweak your diet. We're not asking you to eat kale every day. We're looking to make sure you have the right nutrition, the right protein, the right fiber, but no major wholesale changes. Our doctors say that the best diet lifestyle you can have is something you can live with the rest of your life, not just something you're going to try for 6 months. So it's tweaking your diet, not wholesale changes.
And I think,
Another,
Pete, I think that's one of the myths is, folks see other people that are losing weight, or they see these commercials and they think I'll just have once a week injection and it's magically going to melt off. There's a little more to it than that. And by the way, I love the fact that you send the scale, the digital scale, because most people underestimate what they weigh and overestimate the height. So their BMI is shifted, right?
correct. And we want to treat them as they start to lose weight. As I mentioned,
Right.
making the modifications to their diet, making medication changes along the way. We always consult with their physician. Wherever they're getting their medication today, we are their center of excellence that the physician can rely on to get this type of expertise as we start recommending changes to their medication.
And let me just
One,
pause here for a moment, Pete. Remember, for those of you in the audience, if you have a question, raise your hand. We'll put you on, or address that question. We would really love this to be interactive as we go through this, because this is all about you. It's your presentation. We want to make sure that we're hitting on those spots.
Another major point of difference is that we've been doing this so long that we have 2 very, very large, the largest GLP-1 clinical studies to date. One was issued May of 2025 on the left by Milliman, 4,000 of our state of Connecticut employee customer patients. And you can see the key finding was this medication adherence and 90% persistency rate, combined with some very, very impressive weight loss numbers on a non-GLP-1 as well as a GLP-1 formulary. Our treatment expertise and track record has suggested that the main people who really, really need an injectable GLP-1 are people that have a lot of comorbidities and have a BMI over 40.
Wow.
Almost everybody below those, so BMI in the 30s, we can achieve those same weight loss results using an alternative to a GLP-1. That is one of our secret sauces that has been proven. On the right-hand side is a Siegel study that was issued in May of 26, so just a couple months ago. That took an even larger population, almost 5,000 participants from the state of Connecticut again. This went from July 1st of 23 to June 30th of 24. So a full year following those almost 5,000 patients, and showed that we saved the state of Connecticut over $29 million in GLP-1 pharmacy costs alone, because we were able to get people on the right medication. Oftentimes they're on the highest cost GLP-1, when in fact there was a lower cost GLP-1 generic that would be just as effective but cost several thousand less than what they were on a GLP-1 on an annual basis.
So let's continue that in a second. Daryl has a question, so I wanted to get his question out there. Daryl, what question can we help?
Yeah, I think you just answered it. My question was, when you said you had an alternative to a GLP-1, my question was, what's the cost difference? I mean, a GLP-1 plus a metformin that you could allocate to the member to lose weight. What's the
Yep.
Obviously you just said you just saved a municipality millions of dollars. Can you kind of equate what the difference is in cost?
Yeah, there's two different cost differences. One is if this is a patient who has highly acute case of obesity and need a GLP-1, most of the time we're finding a lower cost GLP-1. They still need a GLP-1, but we're finding a lower cost, which usually averages about $2,000 a year less. The second category is a non-GLP-1. Daryl, you mentioned the metformin. That difference is like $5,000 or $6,000 a year different, less expensive on an annual basis, because these are medications that have been on the market for 15 years.
They're
They're
generic.
generics. They cost $20 or $30 instead of $500 or $600 on a prescription.
And
Can you that being said, right? How does it work in the body? Because GLP-1 versus a metformin, I know they do some of the same things, obviously, because of the weight loss, but how do they interact in the body? Can you kind of get into that too? Like what's the
Yes.
difference in a GLP-1 versus a metformin or something like that? I'm sorry, I'll be
Yes. Yes. They do similar things, but they're less invasive. GLP-1 injectables can be very, very harsh on the body. As you all know, there's a lot of potential side effects, especially if it's the wrong dosage. That's another major secret sauce that our physicians really understand and have experience with, is making sure that it's the right dosage given all their other conditions and given their overall health condition. And so the body is built not to starve. So when people start losing weight, that brain signal gets stronger. And so when they start taking a GLP-1, their appetite is reduced, but also their metabolism rate is slowing down. So they're burning less calories. The trouble is which is why most people fail when they just start GLP-1s and then go off GLP-1s. The appetite comes right back, but the metabolism stays low. That takes 6 months or more to restore. So actually, they're going to gain weight faster than they did before because they have a lower metabolism, and when they go off the medication, their appetite comes right back. Our strategy is to make sure that the right medication is used so that over time we can taper that, we can mitigate that, so that maybe they can go off medication when they are ready, when they've made some dietary changes. It takes about 18 months for our patients typically to reach their ideal weight. And then our physicians move them into what we call a maintenance program. And the maintenance program essentially, and I want to go into this kind of flow chart, but you can see the maintenance program on the far right. Once our people reach their ideal weight, they've made the dietary changes, and the medication dosage we've been modifying along the way, they actually potentially can even go off a medication and still maintain their weight. Some people cannot. Some people may need some form of medication to reduce that brain signal, reduce that brain noise, we call it food noise coming out of the brain, in order to prevent regression. But again, our physicians know that. And so they can get people in the maintenance phase usually lasts another 6 months. And by then people are well on their way. And I'll show you in a minute, we have another clinical study that shows that 70% of our patients keep their weight off long-term.
And Pete, before we get to that point, Bob has a question as well. So let's take that question and then we'll turn you loose on the rest of the information.
Yeah, and thanks, Kay. Pete, kind of a follow-up to Daryl, but from a different standpoint of how are you effectively being able to convince the patient to leave that high-cost TV attracting drug? How are you coordinating that with how are you making that happen for the patients that it's the right way to go?
Yeah, it starts with, and I'm just going to skip ahead just a little bit to this part right here. We start with an education campaign because what we want people to know is that obesity is a chronic condition, as we discussed. We want them to know it's not their fault. This is something that is a medical condition they have, and there are doctors that can treat it. And we start with the education that there are a lot of different medications available. It's not just the ones you see on TV. And our doctors know all this. As you know, there's a lot of skepticism, literally, because so many people there's so many commercials, there's pill form. It's a complicated field. So our education campaign is to let them know that, look, our doctors specialize in this, we're trained in this, and we want to help you. And we achieve success 90% of the time. So then we do an onboarding campaign for people to enroll. And when we do a broader communication, and that's when we get going. So right away, they get the devices, they get the medical treatment plan. They literally go on their phone and schedule their first appointment. And in that first appointment, our doctors are going to know, have they been successful? Are they already on a GLP-1, as you said, Bob? And if they're on a high-cost GLP-1, and they're successful, we will say to them, let's continue this. If you're not having side effects, let's continue. We may work with you on your dietary changes. And down the road, we might have a recommendation and might improve. But we're not automatically taking people off medication because we want people to get to know their doctor. We want our doctors to understand the patient. Most of the time, people will then listen to the doctor if they have a better idea, recommendation that's something that's lower cost, that's going to do the same thing. That's how we convince them. But it's not, we want the communication to be, our doctors are here to help you and optimize your opportunity here and, help you find the most economical medication. So once they understand that we're really about success, we're not about cutting them out of GLP-1s. It's really more about finding the right dosage, the right combination of medications with their other medications, and what can we do long-term, because we're going to be with them long-term, and we're going to make those changes along the way. So that's why we have so much success, that they're talking to a doctor that knows is a pill better for you than an injection? Or is there a combination of a low dose GLP-1 with another medication that's been successful? Every person is different. Every patient has different experience. They have different gastrointestinal needs. And so our doctors, again, and nurses, they understand all of this to create this plan.
So
So
Pete,
that is really,
let's talk a little bit about, you have this comprehensive medical intake session and education. What is the role of an HR or business HR professional in that role? How much if I'm an HR benefit professional, what is my role? What do I have a lot to do with this? Do I have to put 2 hours a week in? What is the output from me?
yeah, the beauty of it, Kay, is that we can get this started literally within 30 or 45 days, because all we really need to start this communication is an eligibility file, so that when people go on, we can check and see if this is covered for their insurance. That's really all we need. We handle the actual content. We'll work with the HR professional on what type of marketing do they typically do to their employees about their health plan. Most of the time, employers are launching this off cycle because it's so important for people to understand this and not get mixed in with the overall open enrollment of the larger plan. So most of the time, it's very successful and simple to start on an off cycle, again, because it's such a hot topic today, and employees are very, very excited when they hear we're doing this for you because we've got a partner now that has these physicians that have this kind of expertise. We're making it available to you, even if we're not covering GLP-1s. Most employers, say under 5,000 employees, typically are not covering GLP-1s for weight loss. Therefore, this is a welcome addition to the health plan because it's for weight management. Even though they made a decision not to cover GLP-1s, this is a very large benefit that HR departments typically want to get in front of their employees as soon as possible, because it's a positive to them. We really do want to help you lose weight.
Well, I think the other part is for an HR professional, especially a small to mid-sized HR professional, taking time out of their work week, out of their day to administer something like this. And I think what I'm seeing from your support, the initial implementation to ongoing support, this individual that needs assistance with cardiometabolic disease, obesity, all of the things that are surrounded that, does not have to go through their HR professional. Correct?
Exactly. All the outreach is done by our care team. All the interaction is, as you can see through the app, where all they have to do is speak into the app and say, I had a hamburger and I walked my dog for an hour today, or 20 minutes. It's really all they have to do. All that information goes into our care team. They can message directly to the care team.
Wait, you mean they don't have to count calories and do a journal?
Correct.
Because I think that's where you lose a lot of people. Let's take another question from Bob.
I think, Pete, I'm just thinking, and Kate, thanks for bringing up the concern and issues for a lot of HR peoples, especially in the small to mid-sized businesses that don't have a lot of time and a lot of resources. But with that, Pete, when's the best? Can you implement this program outside of open enrollment? Because if you're a part of an open enrollment meeting, gotta be honest with you, they're talking about 10 other things, and probably the impact of your program doesn't really hit. So can you implement something like this off renewal?
Absolutely. And that's typically what most employers are doing. It's such a hot topic. They don't want to get mixed up and lost in an open enrollment with so many other choices. Here, it's just about this program that's on everybody's mind because it's on TV every single day. So this is why between 30 and 45-day launch, mid-cycle, separate communication gets it's very, very successful. And enrollments typically happen right away because there's a pent-up demand here. And the employer has the comfort to know that our doctors are going to prescribe the right medication. They're not just going to go to whoever will give them what they want. It's somebody who actually wants to understand their condition and their history. So the employer knows that most of the time it's not going to be a GLP-1. However, we want the members and the patients to know if they really need a GLP-1 medically, clinically, our doctors are going to prescribe a GLP-1, but it's going to be the right dosage. It's going to be the right, maybe a lower cost GLP-1 than what they would have gotten from somebody who's not aware of all these other choices. So that's where the employer is comforted to know that this program is now under control of a doctor that knows all about this disease and has the support to help people and hold their hand to get from where they are today and in roughly a year and a half to their ideal weight, and then make sure that they're going to maintain that.
So Daryl has a question. Daryl, what's your question? How can we help you?
Well, obviously this will work for the self-funded, but will it also work for a fully insured employer?
Absolutely. Because we have such a big impact on the cost of care, because the 70% of the time most of the people don't need a GLP-1. We're going to get them on a right medication that's very, very much, less expensive. So they can use that information when they're talking to their health plan about their premium and negotiate, because we have proven that this works. So yes, we do work with fully insured employers as well as health plans. Health plans are looking for ways for their self-insured population as well. So this is since the health plan carries the risk of cost, this is a very good solution for the health plan as well.
Good question, Daryl. So we have about 5 to 7 minutes left. Daryl, you have another question?
Yeah, just a follow up. So, are you seeing that employers now are utilizing this strategy as a way to lower costs, not only this year but next year and the year after? Because it seems to me that if you could get the weight under control, that the comorbidities that go along with being obese and heavy, the high blood pressure, the diabetes, the other things would lower. Am I thinking the right way? And are employers starting to see this as a business strategy?
Yes, exactly. In fact, the Siegel study that we talked about, not only did we save the state of Connecticut over 29 million in GLP-1 prescription costs, but we saved $100 PM across their entire employee base because of the lower medical costs that came as a result of this weight loss. Both of those studies were done with over 5,000 patients. We have over 25,000 patients under our care right now. And now the employers are seeing the benefit because this weight stays off. Very high success rate means people are staying off, and that's where the longer term benefit of reducing doctor visits, reducing ER visits, and reducing medication costs, all of that now is starting to be realized. As you can see on the bend the cost curve, 225 to 260 PM savings is the result of this successful program.
So in the next 5 minutes, let's say, as we're wrapping up, what are some of the key themes that stood out? Chronic conditions are going to continue to cost a lot of money. There's biggest drivers of healthcare costs. Employees are still looking for that magic pill, but we're also trying to balance that with success rates, right? You don't want to just continually go up on your GLP injection and dose. And then small to mid-sized employers, how can we help them deliver meaningful programs without a lot of administrative time?
Yeah, exactly. Weight loss has been something that's not been achievable for most people over their lifetime. For now, we have medical expertise, we have medication now that can help that wasn't there before. And it's not just GLP-1s, as we know. We have proven that our experience is driven, which is based on evidence. It's based on literally 15 years of experience and a treatment algorithm we developed. And we've delivered the outcomes as proven by these two big studies. We're treating all these conditions, not just obesity. We're treating all of them, reversing type 2 and so on, bending the cost curve. We're in a national platform and a very, very high NPS score of 75, again, since 2018. We are not new to this. This is something our doctors have been training and have treating people for decades, literally. And there are so many other providers that are adding, we can now prescribe. As you know, we're going way beyond just prescribing GLP-1s. We're actually determining what is the right medication combination. It may be a GLP-1, it may be a combination, but it also might be a non-GLP-1 that's just as effective, but significantly lower cost. So employers who are not covering GLP-1s for weight loss, we can deliver a very effective weight management and cardiometabolic program without GLP-1.
Like it.
So I think you might have frozen up a little bit, Pete.
Formulary.
Thank you, Pete. This has been very enlightening. I think the key themes are, for the folks that are listening today, how can they move folks from just GLP-1, that's the only thing for me, into alternatives that will improve their health. And I like the fact that it's virtual. HR and benefits professionals don't have to implement things. It's all taken, the heavy lifting is taken on through FlyteHealth. But there's so many dynamic benefits. We will have this website or this webinar available on the website, and we'll also post it on LinkedIn. But feel free to reach out to me as well. I'm more than happy to share the content with you, put you in touch with Pete. And remember, we also have our digital resource library. And that website or that link is also listed in this presentation. Reach out to me if you're interested in that as well. It's a simple flip book where folks like FlyteHealth are listed, and it's easy, well-vetted vendor partners that we trust and that we align with. And I'd also like to just put a plug in for our next summer school presentation, which is next week. Check my spot, skin cancer, virtual skin cancer at 2 p.m. Eastern time. So you're not going to want to miss this one. This one is, I think, when we talk about costs and we talk about convenience and quality of life, I mean, gosh, I hear so many folks that have melanoma and, the prognosis is not so great, right? So catch it early. But again, Pete, thank you so much for joining the webinar today and for sharing all of this great information. We'll have it available for everyone that's participated, as well as, again, in the website, on LinkedIn. You can reach out to me. Thank you for all of the great information, Pete. We really appreciate it. For those of you, Bob and Daryl, thank you for the great questions. We really appreciated your participation as well. Before we leave, are there any other questions for Pete that we can help you with today? All right. With that, happy Thursday. And again, thank you all for joining the webinar today. Have a good week.
Thank you, Kate.
Bye-bye.